All right, welcome to another class. Hopefully you've done the chapter reading to have a good idea of what we're getting into. This is going to be a relatively long lecture. There will be some slides that I'll be skipping because they're going to cover a little bit more pharmacology, and you will get a pharm class with a few more specific medications that are given usually for coronary artery disease and acute coronary syndrome. A lot of them because of the hypertension medications, calcium channel blockers, beta blockers. So I will be skipping a few of those slides and going faster over those, but hopefully you have a good idea of what you're getting into here today. And one thing I'd like you to keep in mind again is there's a significant difference between thinking about CAD or coronary artery disease and thinking about acute coronary syndrome. The big difference that you're going to notice is that coronary artery disease is just overall, as we'll see in the next few slides, basically a disease of the blood vessel. It's a disorder that is related to atherosclerosis, as we'll see shortly, but it's a blood vessel disorder, it's a chronic disease disorder, it's a lifestyle disorder, lifestyle stress, toxins, food, smoking, drinking, caffeine, so on and so forth. They all affect coronary artery disease. So it's very much an overall large umbrella terminology or term that we use for a heart problem, whereas acute coronary syndrome is what you're going to be seeing when you're in the acute or critical care setting. People are coming in with STEMIs, non-STEMIs. People are coming in with pretty serious problems and major blockages, which would require stents and so on and so forth. So we're looking a little bit more at downstream medicine when we think about acute coronary syndrome or ACS, and we're thinking about overall chronic disease when we think about coronary artery disease. So without further ado, one thing that you want to keep in mind when you think about coronary artery disease is that underlying what coronary artery disease is atherosclerosis, which is sort of a general category. And it basically comes from two Greek words, athery, or fatty mush, and scleros, meaning hardening. So it's a hardening of a fatty mush. And that really indicates quite a bit. Those Greeks seem to have known what they were talking about, kind of like the Egyptians with diabetes, sweet sugar, or honey urine. And so basically it's soft deposits of fat that end up hardening over with age and bad lifestyle, further the dietary habits that we may have that are bad. So it's a hardening of the arteries is what you want to really think about. And so this is just an image to show you sort of how it progresses from the inflammatory response all the way through. It's starting to thicken. At that point, you're starting to see the cells are starting to hypertrophy, and then plaque will start to build up, calcium builds up, which is one of the reasons why we give the calcium channel blockers to a degree. And then the dangers start to happen is when fissure leads to rupture. And of course, meanwhile, the stiffening of the wall is happening all along. And up at the top, you have the highly specific, or the HSCRP, the C-reactive protein, microalbumin, which is looking as well for the microvascular damages that diabetes and plaque buildup can tend to happen. And ultimately, it looks at the LPPLA2, which is if it is in high numbers, very significant of coronary artery disease. And troponins as well is one of the main enzymes that the heart produces that are released into the blood. Again, as you've known from previous classes that we look at in the hospital to determine how long ago perhaps it has happened and how severe it is. Although sometimes with aggressive exercise, it can sometimes lead to troponins being released in the blood as well. So again, you just keep in mind atherosclerosis is the major cause of coronary artery disease. And again, it's related to deposits of lipids that are building up inside the intima, or the endothelium lining of the artery. And of course, that refers to endothelial injury and inflammation, all of which may play a major role in the development of atherosclerosis. So when you think about coronary artery disease and both etiology and pathophysiology. Etiology meaning where the disease or what is the cause of the disease, where is it coming from. You must consider you must consider atherosclerosis. And when you hear the word atherosclerosis, don't forget lipid deposits within the arterial lining and endothelial injury, inflammation, oxidative stress. So the etiology and the pathophysiology are both highly related to each other. So there are some stages of that endothelium in the intima that end up leading to the chronic problems that we're having in society today: heart attacks, stroke, whether it's hemorrhagic or ischemic stroke from the plaque buildup. You can see how that the damage to the endothelium in A leads ultimately to a lot of buildup, migrating lipids and white blood cells and platelets to that area, which of course over time starts to lead to what we call the fatty streaks. Collagen starts to build up. The vessel lumen is at this point in C already starting to be pretty narrowed. So if you're a tobacco smoker and you ingest nicotine, it's going to narrow those vessels even more. So go figure, you know. And then blood flow obviously is going to be significantly reduced. And ultimately plaque will build up to the point where you have a pretty seriously complicated deposit of fat, of fibrous buildup. And so that can either rupture and travel to your heart or to your brain, and that's what we call myocardial infarction, or a stroke of the ischemic type if that plaque rupture lodges in the brain. I like to throw in a couple of things that that I want you to keep in mind. Now, you'll get more of this in your third semester, next semester, especially when we go into diabetes, but also heart problems, because none of this happens in isolation. Everything is happening hand to hand, side by side. So you must start to become familiar with the word metabolic syndrome or syndrome X, because most of the people that are leading into having a stroke, a heart attack, a myocardial infarction, coronary artery disease, that will end up being in the hospital, your patients having some form of acute coronary syndrome requiring either a stress test, a stent to be placed into one of the arteries to open it up and let that plaque and that blood flow to get back to the muscle tissue, which is slowly starting to die. So time is of essence. A lot of this is all related to, and you'll see these people are basically, they have metabolic syndrome. So you have to have 3 or more of these risk factors. You have to have abdominal obesity, right? And that's measured by waist circumference. You have to have high triglycerides above 150. You have to have low HDLs. And you have to have a hypertension. Here, where they're measuring it as above 130 and above 85 systolic and diastolic, respectively. And then a high fasting glucose. And if you have 3 of these, or your patient has 3 of these or more, then you are now officially have the metabolic syndrome or metabolic syndrome X. So most of the patients that you see that have coronary artery disease are going to be patients that are considered metabolic syndrome X. This just goes to show you that really you can't separate coronary artery disease, hypertension from the thrombotic risks that patients end up getting with myocardial infarction or strokes, because hyperglycemia, which ends up with insulin resistance and high triglycerides, especially the small dense LDLs, as we'll get into a little bit later, fibrinogen, platelet aggregation, diabetic cardiomyopathy. The ROS is, again, oxidative stress, reactive oxygen species that ends up leading back to complicating the problem of hypertension, insulin resistance. And so it's this circular problem that leads to the inflammation and to the endothelial dysfunction, the dysfunction of the artery. And remember, coronary artery disease is a disease of the artery. It just happens to be in the heart, so we call it coronary. But right, when you think of coronary artery disease, really it could be manifesting in the kidneys, it could be manifesting in the liver, it could be manifesting, the artery disease could be manifesting in one of these areas. We call it coronary because it happens in the heart, and then we end up having to, the patient ends up having to have a stent or coronary artery bypass graft or more invasive surgeries of different types. So keep in mind that again, inflammation and oxidative stress are playing a major role. Here's just to show a mechanism by which diabetes mellitus, diabetes 1 or 2, especially 2, which is the big killer nowadays, which is, we know, lifestyle related. We know that there's subclinical atherosclerosis, and we're starting to look at some lab blood samples to determine how much at risk a patient is. And some of these new ones are CRP, homocysteine, so on and so forth. And you can see here, even for inflammatory response, they look at the CRP, although the HS-CRP is more significant. And if you have it, well, you're highly at risk for diabetes and for coronary artery disease as well. And so for hyperglycemia, advanced glycation, end product, oxidative stress, you can see that the underlying factors that lead to diabetes, that lead to MI, that lead to stroke, really you can't separate it from its etiology and its pathophysiological approach to understanding coronary artery disease. It's all related with dyslipidemia, insulin resistance, hyperglycemia, infection, inflammation, so on and so forth. And then you end up having all of these factors that we look at in the blood end up when you can measure them, they're considered subclinical because you may not have any obvious symptoms. Although with CAD or hypertension, they're both pretty much silent killers in many aspects, because you may end up having a heart attack or a stroke without ever having had any previous symptoms. So knowing what these underlying labs that we can do and that some hospitals are starting to do and assess for can ultimately, hopefully, we believe, lead to prevent the atherosclerotic clinical event, which is the acute coronary syndrome, or others, but in this case we're talking about acute coronary syndrome as the main one. This just goes to show you that, again, there are these mediators, right? The nitric oxide signaling, the TNF, alpha, redox, RNS, mitochondria, NRF2. These are all mediators that are leading to the oxidative stress related to the micro and the macrovascular, right? Micro leads to a lot of the kidney problems and blindness, and then the macro leads to the coronary artery disease, which is a larger vessel. So coronary artery disease is just a manifestation of all of these underlying problems that are ultimately based off of incorrect lifestyle, stress, what job you've had, what you've been exposed to, have you had toxins, do you smoke, what kind of food do you eat, and all of these put together lead to the macrovascular damage, which is in essence what coronary artery disease is. And again, what I just said earlier, we have to think about the environmental factors and the synergistic reaction or interaction between all of these. So aging, lack of exposure to sunlight, vitamin D, or healthy outdoors, over time cumulative DNA damage, whether you are poverty-associated malnutrition, again due to lifestyle issues, mitochondrial dysfunction, toxins, which include tobacco, alcohol, but quite a few other things, including pesticides as well. We're starting now to realize that a lot of the chronic conditions that we're seeing have to do are directly related to a lot of the pesticides that are being used in our backyard or on the food that we buy from the farm. And environmental toxins, chemicals, antioxidants will help to balance it off. Natural antioxidants obviously are the best, and then micronutrient deficiencies, which again, in most primary care practices and hospitals, we're still not monitoring, but it probably won't be too long before that does start to pop up on the maps of a lot of the primary care docs, we hope. By the time it gets to the hospital, might be significantly far out, but it's something to keep in the back of our mind. Overnutrition, right? We're eating a lot of food, but not necessarily the right food. So we're ending up pretty obese. So the adipose tissue builds up. We go from having lean adipose tissue to having obese adipose tissue. And when that happens, you can see down below that this is the fat. When you hear the word fat is bad for you, I want you to pay attention to this slide and the next one. Pay very close attention, because it's extremely important. When we say fat is bad, we're not referring necessarily to saturated fat of the diet. We're referring to adipose tissue. So there are fats in our diet that are going to be good, and then there's the adipose tissue, which is what ultimately seems to function as a second brain, releasing a lot of endocrinal or hormonal responses and reactions that lead ultimately to inflammatory response, insulin sensitivity, angiogenesis, which is trying to draw more blood to itself, cancer related as well, oxidative stress, insulin resistance, and again, dysfunctional angiogenesis as well. So when we think of fat as the enemy, we're not so much thinking in this scenario, in this slide right here particularly, about saturated fat, which is a dietary fat. We're talking about foods that lead to obese adipose tissue buildup, which is what seems to be underlying a lot of the atherosclerosis and a lot of the coronary artery disease that we have. And again, this is much more related. It seems to be evidence that are coming out to high calories, high carbs, simple carbohydrates and sugars, fructose, glucose, high fructose corn syrup, which is damaging as well to the liver, so on and so forth, seem to be a lot more of a risk factor that lead to that adipose tissue buildup than the saturated fat. So as healthcare providers, I think we really need to distinguish and make that distinction clear. And I hope by the time that not only this slide is done, but by the time you walk out of this nursing program, you'll have a much clearer understanding, and you'll be able to talk with much more understanding of what's underlying the problems that we're seeing. If you still will see, for the most part, the American Health Association, Stroke Society, so on and so forth, they're all still saying low saturated fats. But there's significant evidence and data that are coming out now that are indicating that it's not necessarily the saturated fats, and there's not that much tied to saturated fat in coronary artery or myocardial infarction. We'll see that shortly. Scientifically, what do we need to understand? The underlying thing that we want to understand. Remember, we're talking coronary artery disease here, and this absolutely plays a major role, because all of our patients are going to want to know what they should or shouldn't be doing. So I want you to understand that between saturated fats, monounsaturated and polyunsaturated, the big difference is saturated have no double carbon chains. Mono have one double bond in the carbon chain, and polyunsaturated have two or more double bonds in that carbon chain. And so what you really need to understand is that the less stable forms of fats that we consume are in fact the polyunsaturated fats, like olive oil, right? That is actually a lot less stable and leads to more oxidation. So that olive oil that's sitting in your shelf in Costco, for example, if it's been sitting for a while in the warehouse before it was sent out to the shelf, and then it's been sitting even longer on the shelf, the likelihood is that olive oil, which by and large is a really healthy product, right? We know that the DASH diet, the Mediterranean diet, have proven to have really beneficial effects on the heart, on hypertension, and so we suggest and tend to say olive oil is the good way to go, the polyunsaturated. The only problem with polyunsaturated fats is if they oxidize, which most of these liquid oils do, these are actually a much higher risk for our patients than the saturated fats. They simply are. The science is right there. We know that as the numbers of double bonds in the carbon chains increase, right, that fat or that oil becomes less stable. And so fat that tends to be solid at room temperature, like butter, for example, again, not butter that you just get from, anywhere, but relatively healthy butter, has absolutely no double bonds. So it's much more of a stable product and less likely to form oxidation. Science has clearly demonstrated this as a fact. Yet science has also demonstrated that olive oil is good. The difference is in most of those Mediterranean countries, they go directly to the farms and they buy olive oil that is not necessarily that old, so the likelihood of it having to be formed into oxidation is less likely. So they're consuming polyunsaturated fat that is relatively recently produced. And one way to sidestep this is if you consume high amounts of vitamin E, supposedly that vitamin E can balance off your consumption of these liquid polyunsaturated fats. Look at the, again, this is regarding to sugar, glucose and fructose, which a lot of evidence is starting to say what we're seeing for coronary artery disease, diabetes, metabolic syndrome X overall, is it's much, much highly related to sugars and the glycemic problems that we're seeing, such as type 2 diabetes. So if you look at the yellow, right, very small portion of our population is type 1 diabetics. They're going to always have to be on insulin for the most part because their pancreas will not be able to produce that insulin. But then you have undiagnosed diabetes, which are the green. There's about 7 million people that have undiagnosed diabetes. And then the big problem right here, here's what we're talking about, pre-diabetes. There's almost 80 million, in fact, we believe more than 80 million now, people who are pre-diabetic. In fact, a gentleman who comes and helps me with my backyard sometimes, was asking, hey, can you look at my labs? And he had a 6.6 on the hemoglobin A1C, and his primary doctor hadn't even told him that he had a 6.6 on his hemoglobin A1C. In fact, they said your labs are perfect, your labs are good. And so I had to explain to him that, well, no, that's not necessarily true. He just went from pre-diabetic to diabetic, and this has been happening for many, many, many years. So the fact that the primary doctors are not even talking or mentioning to these patients that this is the fact really ultimately means that down the line when he gets to, of course, if nobody tells him that his hemoglobin A1C is 8.9, 9 point something, 10, 11, 12, of course, what are they going to do? Put him on insulin. And this is something that could have been prevented with just simply talking to the patient or the person. So again, regarding the coronary artery disease, we want to understand that the etiology and the pathophysiology, a lot of it has to do again with the intima, with the lining, with atherosclerosis, and one of the markers for inflammation that we look at is CRP, or C-reactive protein, and CRP is produced by the liver. Again, it's a non-specific marker, doesn't tell you that your heart is inflamed, it tells you that your body somehow, somewhere is in a constant inflammation response, which is a good thing if it's acute, bad thing if it's chronic. And again, we know without a shadow of a doubt that that CRP is increased in many of the patients who have coronary artery disease. And again, chronic elevations of CRP, especially HS, highly sensitive CRP, are clearly linked with unstable buildup of the plaque and oxidation, and especially low density lipoprotein. But I'll talk about low density lipoprotein or LDL cholesterol shortly. The collateral circulation plays a major role, and what you kind of want to understand with that is that if remember, we're talking coronary artery disease. If there's a main artery that feeds blood to the muscle, the tissue of the heart, the muscle, and that artery is blocked, largely blocked, the body is going to start producing angiogenesis and try to create new blood vessels to go around that blockage. But that tends to take quite a bit of time, which is why when somebody is in acute coronary syndrome, dietary issues are not our concern. Our concern is to deblock that as soon as we possibly can, using the procedures we have within the acute care setting. Ideally, we can prevent patients from getting to that downstream situation, but that's not always the case. So collateral circulation just is talking about when that plaque forms, it forms ischemia, and that chronically leads to an increased collateral circulation, which is angiogenesis, creating different blood vessel routes to sidestep where that is. And this is a good image right here. You can see in A, there's no vessel occlusion, right? So look at the amount of collateral circulation is minimal. But once in B, some plaque starts to build up, you'll start to see that collateral circulation builds up more around that area to allow for more blood to get to the other side of where the plaque buildup. And obviously, once it's fully blocked, then the collateral circulation is significantly major or more. And again, the goal of this collateral circulation is to provide blood to the myocardium, right? To bypass the occlusion, to bypass the reason for which ischemia is happening in the first place. Please keep in mind that when we talk to patients about lifestyle, dietary factors, and things that they can change, we want to talk about risk factors that are modifiable. And so pay attention to that. You may see a question somewhere in the future down the line where it talks about non-modifiable risk factor versus modifiable risk factor. And obviously the only ones we can really have an effect upon are not age and gender, ethnicity, or family history, or genetic predisposition, but we can have a major impact on factors that are clearly modifiable. So keep that in mind. So of the major modifiable risk factors, obviously it includes elevated serum lipids, elevated blood pressure, tobacco use, physical inactivity, obesity, diabetes, metabolic syndrome, psychological states, and elevated homocysteine levels as well. These are all things that we'll see as we go along, but basically an elevated serum lipid or elevated lipids is one of the four most firmly confirmed or established risk factors for coronary artery disease. And we know that the risk of CAD is associated with cholesterol levels that are more than 300 milligrams per deciliter, or a fasting triglyceride above 150. So that's one thing that we're going to want to look at. Obviously, you want to have HDLs, which carry the lipids away from the arteries and to the liver. They're kind of like the drivers. We want to have more of the HDLs, so lower HDLs, as we saw earlier in that chart for metabolic syndrome X, is important to have. So we want to have higher of those. And in general, HDL tend to be higher in women, and they decrease with age, but exercise tends to help significantly. And HDLs will tend to be lower in patients that have coronary artery disease. And so physical activity and moderate alcohol intake can help increase HDL over time. So we want to keep that in mind. And again, when we think elevated serum lipids, we have to think atherosclerosis, we have to think artery disease, we have to think that what's happening is that those lipoproteins are being attached and attracted into the arterial walls, which ultimately create more elevation of LDL over time, more plaque buildup, more atherosclerosis, and ultimately coronary artery disease and death. And then it requires a stent perhaps before they die, hopefully, so we can open and get that blood flow to move back in. Hypertension, we've had a whole lecture on that. I'm not going to really go into that. You already really know that it's pretty much, I think, perhaps first or second major risk factor of coronary artery disease. And again, it's a blood pressure above 140 over 90 or above. Or in people who are elderly, remember 150 over 90 is what we're going to be looking at. So lifestyle changes are major, and they should begin in people that have blood pressures between 120s and 139s over 80 and 89. Don't wait for it to be too late to start having that conversation with your patients. Tobacco use is clearly another of the four major risk factors. We've said two already, LDL, especially the small apolipoproteins, but we'll get to that in shortly. But increased LDL, increased blood pressure, and tobacco use. If you're smoking, I tell you, risk factor for a lot of the complications of metabolic syndrome X, which lead to diabetes, which lead to MI, stroke, CAD, tremendous direct relationship between tobacco use and all of these chronic conditions. And again, tobacco is tied into increasing that LDL. Tobacco will decrease your HDL. Tobacco releases toxins into your blood. Those toxins are oxygen-free radicals. Again, and all of that is adding to that vessel inflammation and that thrombosis. So, hey, smoking is one of the worst things that patients can do. We have to have that conversation with them. And again, remember that carbon monoxide is found in a lot of the tobacco smoke. So there's first-hand smoke is when you smoke yourself. Second-hand smoke is when your partner who doesn't smoke sits next to you when you do. Third-hand smoke is when you're really self-conscientious and you say, oh, I'm going to step outside so I don't infect you. And all of that smoke gets all over your body. Yeah, you're smoking outside, so there's no secondhand smoke, but there's third-hand smoke. You come in and hold your baby with the clothes that you were wearing when you were smoking, even though you stepped outside onto the patio to smoke. That can completely pass on to your family and relatives and in children by third-hand smoking, and we know that carbon monoxide significantly decreases oxygen availability to the heart muscle. It's an irritant, it's a chemical, and it leads to injury again to the endothelium. So quitting tobacco is one of the most important things. Physical inactivity is the fourth and major modifiable risk factor that we look at, that we know about. So regular activity is one of the most important health promoting activities. Brisk walking, 3-4 miles, per hour, at least 30 minutes, 5 or more times per week, ideally, is the best way to go. And again, we know that the death rate from CAD, coronary artery disease, is much higher in obese people who have that adipose tissue buildup. And that means, from a body mass index perspective, above how much? Anybody remember? Above 30 kilograms per M2. So keep that in mind. Or a waist circumference above 40 inches for men or above 35 inches for women. And those people who store more fat in the abdomen, that sort of apple versus a pear, have higher incidence of coronary artery disease. And so again, obesity is clearly linked to coronary artery disease, and that has a lot to do with the foods we eat and whether we're active or not. Diabetes and metabolic syndrome X, I've increased by about 4 to 5 times greater in persons who have diabetes. And so controlling blood sugars, hopefully with diet, is very important. And management of diabetes really is lifestyle, right? We tend to say, you'll see that mostly, they like to say we like to keep the hemoglobin A1C less than 7, but really we really should be targeting 5.4 or 5, 4.8. But in a lot of patients that have chronic diabetes over long periods of time, that insulin resistance is built up to the point where it's going to be hard to get them back down, but it's not impossible, especially in type 2 diabetes. So other modifiable risk factor, again, remember, these are all things that we can modify. Age you can't, gender you can't, and type A personalities, right? We know that perfectionism, hardworking, driving personality, over time leads to a lot of stress and tension, and we know that leads to significant risks for CAD and MIs over periods of time. There's a lot of evidence that leads to that. Other psychological risk factors that go with people who have hypertension and myocardial infarction, history of, or coronary artery disease, is depression, right? Anxiety, hostility, anger, lack of social support, all of which, if you're poor and you eat improperly, or you just don't have the money to eat properly, although one can relatively well eat a good diet with little money, depression, anxiety, all of these things will exacerbate the circulating catecholamines, that stress response, remember, and that the catecholamine increase leads to endothelial injury, inflammation, and platelet aggregation. So if you think that there's no relation between psychological stress to the underlying inflammatory platelet reaction and endothelial injury, think again. And we know that higher levels of depression are associated with increased number of adverse heart events. And so that plays a major role. And homocysteine is another one of those that you really want to keep in mind, because high blood levels of homocysteine are clearly linked again to a risk for coronary artery disease and cerebrovascular disease as well. And so it's produced homocysteine is produced, basically it's an amino acid, a breakdown of methionine, which is found in dietary protein. So what does that mean? It means that when you have high homocysteine levels, that breakdown of that protein, it's going to contribute to atherosclerosis in multiple ways, 2 main ways, right? One is, again, I won't tire of saying that, damaging to the inner lining of the blood vessel, and 2, promotes the plaque buildup. And 3, it actually promotes clotting mechanism. So clotting is more likely to happen with high homocysteine. So and so what do we know? That B complex vitamins, especially 6, 12, and folic acid, are known to lower homocysteine. So yeah, if you'll hear many times that, hey, those vitamins are expensive urine. Well, if vitamins are expensive urine, how come we know that B6, B12, and folic acid, or a lack of subclinical levels of these levels? So you're not deficient, you're not insufficient, you just don't have enough. And of course, how would we know if you're insufficient or deficient if we're not measuring it? We're just not measuring it. But so how are we measuring it? Well, indirectly. If you have high homocysteine, the likelihood is your B6, B12, and folic acid are going to be low. So by taking a good B complex vitamin, hopefully in a whole food form, you could reduce the risk for homocysteine, and we know if you reduce the risk for homocysteine, you're reducing your risk for coronary artery disease, cerebral or cardiovascular disease, MI, stroke, so on and so forth. So generally, screening for homocysteine is limited to people who are suspected for having elevated levels. So if you have metabolic syndrome X, and a wider waist circumference and hypertension and a low HDL or high HDL, if your doctor's not doing homocysteine on you, then get yourself another doctor or find one that's willing to do that. Because if you're having all of those signs of syndrome X, metabolic syndrome X, get a check for that. And then substance abuse. No, needless to say, if you're on cocaine, methamphetamine, reduces spasms in the heart, myocardial ischemia, leads to chest pain. A lot of people who end up in the ED have drug-induced chest pain, right? And it's really hard to determine that from coronary artery disease. Mostly what you'll see is, even though a lot of substance abuse patients that come in can end up having a myocardial infarction, what they'll have is sinus tachycardia, the high blood pressure, angina, and anxiety. And ultimately, if we can control for those factors and calm them back down, they can be discharged, and they will without a coronary problem of any type. So, 2 risk factors for CAD, coronary artery disease, that increase the workload of the heart and increase myocardial oxygen demand. So the heart is the myocardial, the muscle of the heart, is going to be saying, I need more oxygen. That's what myocardial oxygen demand is. The heart muscle, myocardial, saying, give me more oxygen. What do you think it is? Obesity and smokeless tobacco, hypertension and cigarette smoking, elevated serum lipids and diabetes, or physical inactivity and elevated homocysteine. Well, you could almost say all of the above, but we're really looking at the two risk factors is what the question is asking. So hypertension and cigarette. If you see cigarette smoking and hypertension, we know those are 2 of the biggest risk factors for vasoconstriction. And when you're vasoconstricting, because cigarettes have nicotine, we know they vasoconstrict, and a high hypertension is also going to lead ultimately to that vasoconstriction. We know that atherosclerosis, again, you must always tie in coronary artery disease to atherosclerosis. Atherosclerosis, coronary artery disease, brothers, hand in hands. They're holding hand in hands, leading to that ultimate vasoconstriction, which leads to an increased workload of the heart. And when the heart has to work overtime by enlarging itself or going into tachycardia, or maybe even having palpitations, you end up having more increase for need for oxygen. And so your myocardial oxygen demand is going to go up. So of this questions, what do you think the answer is? Which patient is most at risk for developing CAD? Is it a patient who has hypertensive patient who smokes cigarette? Is it overweight who? This is the same question, I think. Again, tobacco. We also know that high lipids and hypertension are 2 of the 4 main ones. So always be looking for hypertension, be looking for lipids. But when you see smoking cigarettes, there's pretty much nothing out there that can put patients at risk more than smoking tobacco, if you ask me. And most of the science. In fact, it's not me saying that. It's a fact at this point. So nursing and interprofessional care for CAD, well, obviously health promotion, and this really is it can be quite deep and in-depth response, and we really don't have time to go into it, but really you want to prevent, modify, slow the progression of that disease. And what is slowing the progression? Slow atherosclerosis. If we slow atherosclerosis, we can slow coronary artery disease. We can slow cerebrovascular, we can slow cardiovascular, we can slow ischemic disease, stroke, we can slow all of these things. But the only way to slow these things down is to really talk to our patients. I mean, if a patient is leaving a hospital after having a stent and nobody talked to them about their ability to control their glucose, their ability to control their blood pressure, their ability and what types of foods we should be consuming, then shame on us. As a healthcare institution, we're not doing our job. And as a nurse, we're not doing our job. And as a surgeon, we're not doing our job. And unfortunately, a lot of these patients are coming out of the hospitals without anybody having a health promotion conversation with them. Don't be that nurse. Make sure we talk to the patient, right? Most clinical manifestations with CAD will not be apparent in the early stages. So we have to talk to them and identify what those risks are. If they're eating foods that are highly processed foods, I'm not going to go into the diet here. You guys know what the risks in the diet is, and what we need to be talking to their patients. We've had this conversation previously. And a lot of times, even if they only are in for hypertension, and just quote unquote a scare, it's not really, we didn't find any blockage of the artery, but they did feel some of that angina. Remember, angina is sort of that chest pain, right, that pressure, but we didn't find blockage. We still need to be telling them that most people who do come in with a lot of these problems, cerebrovascular, MI, stroke, it all happens silently. They may not necessarily have symptoms manifest ahead of time. So it's important for them to talk about tobacco use, limit the alcohol, try to work on stressful events, right? Events, if they have a loss of a spouse. These are all things that can put them more at risk, right? Also to work on any negative psychological state, anxiety, depression, anger, try to, as much as possible, distance themselves from situations that externally are causing them, or eat proper diets, which we know that there are doctors in Harvard that are using micronutrients to treat depression and anxiety, and their effects are fabulous with micronutrients. But again, a whole food diet is the way to go. And then if they work in somewhere where their activities or they're exposed to pollutants or toxins, then really that needs to be part of the conversation, although in many of the cases they may not be able to remove themselves from that because that's their source of livelihood. But there are tests out there that some primary doctors can look to see if they have any metals in their blood, and so on and so forth, which in many cases are causing a lot of the underlying problems at the endothelial level. Chelation therapy, again, chelation therapy. That's usually something that in most nursing programs you won't hear talk about. But the evidence that is building up to demonstrate how beneficial chelation therapy for patients that have all of these metabolic syndrome X factors that are risk factors that are leading to coronary artery disease are tremendous. So we have to talk about what they believe health is about, whether they're hiking, whether they're oxygenating themselves, going out to to nature, whether they're drinking water, are they eating fiber? Fiber we know works with a lot of the lipids, as we'll talk about later, and so on and so forth. Further nursing and interprofessional things we need to keep in mind: encourage lifestyle changes. Boy, if I can't, drill that into you guys enough, then I don't know. I don't know what else to say, but we need to be drilling this into our patients. The problem is a lot of patients haven't ever received any education about this. So talking to them about what stores do you buy your food in? Are you able to go to a store where they sell meat that has no antibiotics and no hormones? We need to clarify what their personal values are and let them come up with what change they want to make. And the point of making setting a realistic goal is really saying, hey, we don't want to tell them, you need to make sure you go to Napa, go to a farm, buy all your meat, all your eggs, all your milk, buy raw milk. We can't say that. We can't off the bat say that. If we can pinpoint that they smoke cigarettes, for example, and if we can pinpoint that they drink a lot of soda pops, high fructose corn syrup, for example, or anything that contains that, or aspartame, for example, which is mostly in diet drinks, then we can say, okay, well, that's what we're going to work on. We're going to work on tobacco first. We're going to work on, if they could change one thing, start with tobacco, right? If they need help, we'll help them with that. If they're unwilling to and they don't want to change their tobacco habits, and they tell you, some patients are forward, say, look, would you at least consider cutting back on your drinking Coca-Cola, Pepsi-Cola? Start with that, right? And if that's one thing they can do, we start with one thing. It's a small change that's measurable, and over time, if that's the one thing. But again, remember, when we talk about Coca-Cola with them, we need to say why about Coca-Cola. Remember, simple carbs build up glycemia, diabetes, ultimately is all related to a lot of the and it's a lot of the simple complex carbs that patients are eating are leading also to a lot of that cholesterol, the LDL buildup, which ultimately leads to the plaque. And so sugar is a big thing. So sometimes starting with one thing and only one thing is extremely important. Obviously, exercise as well, which is this right here. We need to make sure that, well, we know that if they do perform exercise, they can drop their blood pressure, they can increase their HDL. If they at least do 30 minutes of weight training 2 days a week, or walking 4 to 5 days a week, 30 minutes each time, then we know that that they can improve their health. The FIT formula is referring to frequency, intensity, type, and time. So frequency is how often, intensity is how hard, type is isotonic, and how long is over time. So at least, again, the goal should be at least 30 minutes of moderate physical activity most days of the week, at least 5 days. Weight training should be added at least 2 days a week, especially to help people that have metabolic syndrome X, to help improve their muscle strength. Brisk walking, hiking, biking, and swimming could be added on top into their FIT program as well. And again, ultimately the goal is weight reduction, because weight reduction really is talking about what is weight reduction talking about? Remember, obesity is linked to what? Obesity is linked to buildup of adipose tissue. Adipose tissue works as a second brain, cutting off the satiety center. So the person that has a lot more adipose tissue is constantly feeling hungry, because the adipose tissue that works as a secondary brain cuts off the satiety center to tell the body, you're always hungry. So they're always going to go to that fridge and want to eat. So weight reduction really is talking about trying to reduce that adipose tissue, because we know adipose tissue leads to atherosclerosis and plaque buildup. And we know that atherosclerosis and plaque buildup is related to coronary artery disease, which is the lecture we're talking about. So you see what we're talking about. Nutritional therapy. We know that the National Heart, Lung, and Blood Institute is really recommending therapeutic lifestyle changes for all people. And we know that it reduces risks of CAD by lowering the LDL and the LDL cholesterol, right? Remember, a lot of people think by lowering the LDL cholesterol, we should be lowering saturated fats. And yes, we don't want to consume too many saturated fats. Less than 30% of our energy should be from fats anyways, unless you have a very specific diet that has really low carbs and really high fats. If you're consuming good fats, healthy fats, in many patients, even diabetic patients, we've seen some beneficial results in eating high fats. So the lowering of saturated fats, that LDL cholesterol, really ultimately should be about sugar, should be about adipose tissue, should be about trying to reduce the risk of plaque buildup and atherosclerosis due to the diets that we're eating. So these recommendations really emphasize that mostly, for the most part, you want to think of saturated fat. Cholesterol is what we should be reducing, right? And but what they're really saying is eat more complex carbohydrates like whole grains, fruits, and vegetables, and fiber. But when they say eat more complex carbohydrates, really, again, they're trying to say reduce the sugars, right? Red meat, eggs, yolk, whole milk, generally we want to try to reduce them. Again, if you do eat them, try to eat them from a whole source, from markets that, even though they may be a little bit more expensive, they tend to have no antibiotics, no hormones. That makes a major thing. Now, omega-3 fatty acids, remember, omega-3 fatty acids, especially EPA and DHA, the alpha linoleic acids, we can get them in our diet, but they're part of that polyunsaturated. And remember, polyunsaturated have more than two double bonds of that carbon chain, which means they're at higher risk for oxidation. So in fact, we have to be careful. Even fish oil could be oxidated, produce some of that oxidative stress within our body. So again, generally speaking, you want to think that low saturated fat, although really it's more low sugar. There are good fats like avocado just in a small amount. High fiber diet, clearly avoid tobacco, increase physical activity will promote the reversal of coronary artery disease and overall reduce coronary events. Dean Ornish has actually, through diet alone, been able to completely reverse plaque buildup. This is an MD from UCSF. He's written many books, and his lifestyle, therapeutic lifestyle or intensive lifestyle intervention really is a dietary intervention. So don't let anybody ever tell you that diet cannot reverse plaque. It can. It's been proven. They've had 100% blockages. They've been able to reverse those completely on certain type diets, mostly plant-based diets. And so that said, butter is a saturated fat, and if it's of a good source of butter, yes, it's saturated. It may be better in some cases than if you're eating a polyunsaturated fat like, for example, olive oil, if it's been sitting on a shelf for long periods of time. And most of the olive oils that you're getting from your markets are probably already oxidated. So we have to be careful with that. We have to, it's a very complex science, and we have to really think about what we're putting into our body. Again, this shows the arterial vessel wall, what happens in the blood, LDL, very low dense lipids, monocytes, HDL. We know we need those to process the bile through the metabolization in the liver. And we know that, again, in the arterial wall, what's happening is a buildup of that plaque through inflammation. Perhaps even now some autoimmune. They believe that people who have celiac disease as well may be leading to a lot of this metabolic syndrome X, which leads ultimately to the plaque buildup and to inflammatory responses, especially within the body. Types of syrups, of lipids, cholesterol, triglycerides, phospholipids. Again, the polyunsaturated fats are going to be the 3s, the 6, and the 9s. For the most part, all of them, again, all of them, the 3s, the 6, and the 9s are good. We need them for our body. But because the standard American diet with eggs and meat and so on and so forth tend to have higher 6 and 9s, you might hear some people say 6 and 9s are the bad ones. They're not bad ones, except that we already have a lot of them in our body. What we need to have more of is omega-3s through consuming salmon, fish, or some form of fish oil, or natural vegetarian or vegan oil that can provide you with good EPA and DHAs as well. And then the cholesterol on the other side is what ultimately leads to the LDL buildup, which we'll talk about a little. Now, unfortunately, a lot of nursing programs won't talk to you about patterns of lipids. And so what I want to give you is that, and let me start with this next slide here. So if you have 130 or 140 or 150 or 160 of large LDLs, pattern A's, the large apolipoproteins that are larger in size, and you have that same amount, 140 or 150, 160, 200 of the small low density lipoproteins, which we call the pattern B, are you going to have the same risk? Absolutely not. There's much higher risk with the small LDLs, which are the ones right here. As you can see, that oxidation, see that bottom part right there where all those little yellow circle balls are penetrating? They have rapid and easier entry into the blood vessel, the arterial wall. And if you haven't yet come to understand what coronary artery disease is. Now remember, that patient who you're going to be having in the hospital who's having acute coronary syndrome requiring a minimally invasive stent or a maximally invasive chest-crushing, sternal-crushing coronary artery bypass graft, it's all related to these things that can be completely preventable upstream rather than waiting for it to happen downstream. And so large LDL pattern A are not that much of a risk, people. It's not that much of a risk. So most of your primary doctors should be now looking at the patterns of the lipoproteins. And again, one of the biggest dangers in patterns is low vitamin E. If you have low vitamin E in your lipoproteins, you are much more susceptible to oxidative damage, which is why a lot of people say if you are consuming those PUFAs or polyunsaturated fatty acids like olive oil, which we know that Mediterranean diet and the DASH diet have proven good. But remember, oh, my uncle just gave me some olive oil that he just got from his farm, a couple weeks ago. How many of us are eating like the Spanish on the coast of Valencia or Malaga or in Italy are getting that source of olive oil? Very few of us. We're getting it from the shelf of a store, so probably highly oxidative. And so ultimately, all of this leads to high blood insulin. High blood insulin. What's another word for that? Hyperinsulinemia. Hyperinsulinemia. High insulin. Insulin is pro-inflammatory. So when you have these small, dense, low vitamin E, more oxidative damage, your insulin is going to shoot up, and after a meal, blood fat level doubles in pattern B more than A, right? All right. So we have to be very careful with the types of fats we consume, right? But let's not blame saturated fat, and we'll go into that very, very shortly. We looked at this really well, not well, but briefly earlier. And again, this is just showing you that pattern A and B. The A pattern is going to bounce off of that vessel wall, and the small or the B's are going to slip right into that endothelial cell, which ultimately cause damage leading to atherosclerotic plaque buildup. And what do we say is linked to atherosclerosis? Coronary artery disease. In fact, every major disease that we talk about. In fact, this could be the introduction to a lot of the peripheral vascular disease. This could be the talk about a lot of the ischemic cerebrovascular problems that patients are going to have, whether it's a vessel that ruptures and you end up getting a hemorrhagic stroke, or a plaque that builds up and lodges in the brain, you get an ischemic stroke. You see that the pattern is all happening at that vessel. And so if your doctor is just looking at your LDL, that really is not saying much. So many doctors are now starting to look at that pattern B, hopefully. Types of saturated types of dietary fat, we're not going to go into that. Saturated, mono, poly. Remember, polyunsaturated have more than two. They're a lot higher risk for, and the biggest problem, there's some evidence out there that says, when did a lot of our strokes, heart attacks start to happen in the United States? Well, back in the day, when good old grandma was serving lard and of a natural source of lard, not some synthetic factory lard, but real lard and butter, right? Go back to those days and see how many heart attacks were really happening. It's curious data, right? I'm just saying, let's look at that's what's happening. So when these liquid vegetables, so when they started to say that saturated fat, right, coming out of butter, for example, was the enemy, what do? They gave these synthetic margarines that had hydrolyzed or partially hydrogenated fatty acids that were horrible. These bent chains that once you were consuming them were literally causing everything we're talking about in this lecture. At the endothelium with the coronary artery disease. When you hear artery disease, you need to think about all of what's happening there in inflammation, plaque buildup, oxidative stress, and indeed getting away from that saturated fat such as butter and going into all of those synthetic forms of margarine was perhaps one of the worst things that could have happened. In fact, a lot of people still to this day will go buy that margarine and not buy real butter because they still think that low saturated fat. Again, use sparingly. That's the goal. I'm not saying consume high amounts. So I brought this in. A lot of these I've looked for you so that if you have any doubt, you can go look on your own. But in March, very recent, Journal of Annals of Internal Medicine published a meta-analysis. Okay, so when you look at the pyramid of research studies, there's two studies that are of the highest quality: systematic reviews, meta-analysis. So when you hear meta-analysis, pretty hardcore, pretty solid foundation of research with this. So this meta-analysis brought together 76 scientific studies, and they looked at the effect on various fats on heart disease, right? And the association of dietary, circulating, and supplement fatty acids with coronary risk is the title. The conclusion that these researchers came to after reviewing all of these 77 scientific studies was, really, current evidence does not clearly support cardiovascular guidelines that encourage high consumption of polyunsaturated fats, such as olive oil, right? Unless you eat the good olive oil that we know is not oxidative, then you're safer. And low consumption of total saturated fat. Again, does not clearly support low consumption of total saturated fats, right? And yet people are still buying low-fat milk and low-fat yogurt and low-fat because that's what the public policy, public health policy, national public health policy is still out there. And again, remember, when it comes to our lungs, one of the most important things is phospholipids, right? What phospholipid in the lung is essential for breathing properly? Well, we all know it's the lung surfactant. Well, what is surfactant made of? It's a phospholipid, right? Surfactant in your lung is a phospholipid. It's a special phospholipid in your lung made out of what? 100% saturated fatty acids. 100% saturated fatty acids. Just an FYI. Okay, let's answer this question here. I'll let you read that really quickly. I'm going to take a sip of my tea. So what do you guys think? Teaching about implementing dietary changes, decrease the risk of CAD, have been effective when? Well, the truth is, since we know okay, so let's think about this. Monounsaturated fats are found in natural foods like nuts and avocado, and it is a saturated fat, and they're the main components, like, I don't know, olive oil, oleic acid, tea seed oil, things of that nature, right? Canola oil is 60% of monosaturated. Olive oil is about 75% monounsaturated fat, right? And so the answer to this really is that we want to use fat intake for energy should be less than 35% of our calories overall. With sparing amount of saturated fats. But if you are going to consume some of the saturated fats, generally speaking, because of this research from the DASH and the Mediterranean diet, olive oil and nuts are still considered the healthiest available forms of fat that will help decrease the coronary artery disease. And again, I have to stress that olive oil is a polyunsaturated fat, so there's a lot more higher risk. It's a lot less stable than butter. And that means that olive oil is a lot more prone to oxidation than butter. That said, most of the studies that have looked at the Mediterranean diet, we believe, have looked at diets of people who are eating olive oil that was created, produced, squeezed out of the olive relatively recent to their consumption. So a lot of that oxidant buildup and oxidation of the oil has not necessarily happened. But clearly olive oil, clearly nuts and avocados would have been another option. So C is the right answer to this question. Remember, when you talk about coronary artery disease, we cannot not talk about what we eat, what we put in our body. And so if you ask me personally, and again, I could be wrong here, but again, go out and prove yourself, learn, read articles, show me what you have. If they're meta-analysis, systematic reviews, even better. But we have to, as healthcare providers, constantly be thinking about what evidence is, because evidence is going to change. And what we know today, tomorrow might be wrong. And what I think we know today, that saturated fat or low fats is what we should be, is wrong. I think that saturated fat, really, again, there's not that much evidence that the big thing we should really be talking about is tobacco, sugars, so simple carbohydrates, right, are the key things, especially if you're drinking sodas, to look at. All right, so about this, again, remember that cholesterol levels in this country, there's, I don't know, 40 plus million Americans have tremendous levels of cholesterol buildups. Now, cholesterol, again, remember, is not the bad guy. Every hormone in your body needs cholesterol to be able to produce, for your body to be able to produce it. So having low cholesterol can be pretty risky. In fact, some studies have shown that elderly patients with low cholesterol are at more risk for mortality for multiple reasons, not only myocardial infarction, than patients that have higher cholesterol. So we have to start taking these things with a little bit of a grain of salt. And start questioning things. It's always good to question. Now, of course, the first thing to go to is always should be diet and exercise. And then we can tell them, hey, if your diet and exercise isn't doing it, then statins will do it. A lot of people just jump to the conclusion, if I'm on a pill, if I'm on a drug, everything is being solved and I can eat what I want. And what we need to say is, look, if you're not changing your diet and your exercise, you will be put on a statin. But statin has some side effects, right? Muscular problems in the legs or liver issues as well, because that's where it works upon. That's the pathway that it's working on. So we have to really tell them that weight loss and dietary changes are the way to go, and that taking a statin is not going to be the solution to it. That if they take the statin and still don't change, that statin is only going to make the situation worse if they assume that the statin is the solution and that the diet, they don't need to change their diet and their exercise. But again, when they're on a statin, we have to monitor their liver for damage and myopathy as well. So we have to be careful with that. I like to introduce psyllium husk as one of the best things to help with managing weight, cholesterol, digestion. We need to get fiber. Yeah, you go to the hospital, and what are they going to give you? They're going to give you Metamucil. It's going to be in a nice little orange pack box, and it's going to have like an orange flavor. And you're going to probably be paying 80% more for that box and that flavor than you are if you go to a Whole Food store and buy psyllium husk, which is the natural form of fiber. But again, with this, you have to start low, go slow, eat a tablespoon in the morning and a full glass of water, and then to do that maybe in the evening for a couple of weeks, and then you can add up to 2 tablespoons. But it's pretty effective. You just don't want to start it too much and too fast for various reasons. Niacin, anybody remember what niacin is? It's a water-soluble B vitamin. Anybody remember? B, is it 1, 2, or 3? How about we go with 3, B3, and it lowers LDL. One of the problems that a lot of people complain about, although it's minimal and it is flushing, some itching, GI side effects, but really it has shown to help the liver in increasing HDL and multiple other things, and inhibits LDL, that those lipids. The question is, does it inhibit the B's as opposed to the A's? I haven't looked into that research, so unfortunately I can't give you that type of information because I haven't looked to it. I give you what I have. Then if niacin or fiber doesn't work, we always can add on fibric acid derivatives. And they work by basically aiding the very low dense lipids. They increase the production of the apolipoproteins A1 and A2. They're perhaps one of the most effective drugs right now for lowering triglycerides, TGs overall, and increasing HDL. But if we can start, but they do have some side effects. Most patients tolerate it well, but again, similar to niacin, it may have some GI side effects as well. So B3, what foods do we have out there? If we can get it from a diet as opposed to a supplement, by all means, unless the supplement is sourced as a whole food. But again, even as a supplement as a whole food, it's still a supplement. So it's relatively synthetic, right? Just maybe a little bit better than a synthetic drug, but it's still synthetic. The best step is to take the food. If the food doesn't work fully, then take the food and add in a B3 or a niacin in a supplement form. And then if the whole food and the B3 doesn't work, but by and large, if one on a daily basis regularly eats healthy foods, you can see that niacin will help lower the cholesterol levels. And dates, tomatoes, broccoli, avocados, mushrooms, asparagus, great for producing glutathione, the precursors to lead to glutathione, the mother of all antioxidants. Swiss chard, pumpkin seeds, you get the point. B3 is really important. This is just a slide that I added in there to show you that niacin works on the adipose tissue to decrease the free fatty acid release, which helps the production, that it helps the liver not produce triglyceride or synthesis of triglycerides, which ultimately decreases LDL, increases HDL, and has a very positive effect. Niacin, B3. So I'm not going to go into a lot of the drugs, as I said earlier, because we're going to have a class entirely on that. But there's The lipoprotein removal is bile acid sequestrants. They sequester that bile acid. And then there's the ezetimibe or the Zetia, which is a common one as well. It inhibits the absorption of dietary and biliary cholesterol through the intestinal wall, and so on and so forth. We'll go into this in a little bit more detail. You know what aspirin and Plavix are what? They're antiplatelet therapy, we got to watch out with bleeding, especially with Plavix. But remember, if we know that coronary artery disease is is related to what? Atherosclerosis. And what does atherosclerosis mean? Well, again, think at the molecular level. Three things. You got to tell me three things. Inflammatory response, build of the plaque, with the CRP and the homocysteine, all of that, right? So that inflammatory reaction, but also the oxidative stress and perhaps even an autoimmune. Now, with aspirin and a lot of these other medications like clopidogrel or Plavix, you have to watch out. If they have a history of a GI bleed, we may not want to give them these because it can just put them at more and more risk for hemorrhagic stroke and so on and so forth. And of course, if they've had a hemorrhagic stroke, definitely don't give them any of these. For elderly and gerontological, remember the incidence of heart is highly increased in the elderly population. So often coronary artery disease in these patients just is a complex relationship between their aging, which is to a degree somewhat of a fallacy, because we know that if the patient, in an elderly patient does exercise, they could have better arteries than somebody in their 40s when they're in their 70s, perhaps. Right? If you smoke and drink a lot of alcohol, take drugs, and drink soda pops all day long, and don't eat any vegetables, nutrients, micronutrients, so on and so forth, and you don't exercise, and you have a stressful job, your arteries when you're 40 are going to look worse than somebody who are in the 70s. But still, we have to consider that with aging, some normal processes will happen, so we have to keep that into mind. So strategies to reduce coronary artery disease risk and to treat coronary artery disease are really effective in this age group. We just have to be careful with aggressive treatment with hypertension and hyperlipidemia in a lot of these patients, because it can trigger them to the opposite response, which we don't want to happen. Similarly, we should really encourage these elderly patients to consider a program, some type of a planned program to get them into activity performance, endurance, and of course it has to go with their ability to tolerate the stress and how much they can do. Hopefully, and that's all a part of an assessment that we would have to do with the patient to determine how much they can walk. Obviously, if they can't walk, then that is not going to be an option. We have to go. But when planning physical activity, for an elderly adult, just basically recommend longer warm-ups, longer periods of low-level activity, longer rest periods in between. So don't overstress it. Walk a little bit, rest a lot. Walk a little bit, rest a lot. Right now, if they're able to walk a lot and rest a little bit, great. But not everybody can do that. So we have to go with what we know and what they're able to do. The clinical manifestations of coronary artery disease. Now we're starting to get into, here we're moving into a little bit more of that acute level, as we'll see as we go into here, but you must be familiar with the level of what angina means. You have to know what angina means, and you have to know the different types of angina, right? So angina just is chest pain. When you hear the word angina, think chest pain, and it's a clinical manifestation of myocardial ischemia. And what is myocardial ischemia? Myocardial, muscle of the heart, ischemia. So break down these words. Ischemia means somehow blood is not getting to where it should be. Generally speaking, a plaque buildup, some form of obstruction is not allowing blood to get to the myocardium, to it's one part of the heart. So as blood doesn't get to that part of the heart, that heart area starts to die, because without oxygen, without blood, right? Oxygen and nutrients don't get there. That's what we call myocardial infarction. That's another word for myocardial ischemia or an infarction is infarction or is a heart attack, right? So one of the manifestations of coronary artery disease is angina, which is chest pain. And it's usually really tied hand into hand with, think about the molecular level of the endothelial cell. If that plaque buildup gets to a point where blood can't get through, at some point you're going to be putting your hands to your chest saying, oh my God, I feel a lot of pressure. It just means that that has been happening for a very, very long time. Everybody thinks myocardial infarction or heart attack happens suddenly. But yes, it does. The sudden chest pain, the sudden angina the manifestation can happen suddenly. In fact, it can kill you suddenly. It's a silent killer. But the buildup at the endothelial level and the artery disease, coronary artery disease, over time has been happening for many, many, many years. Buildup. In fact, people in their 18s still have quite a bit of it. So we need to think about coronary artery disease really as a chronic and a progressive disease. And patients can be asymptomatic, just like with hypertension. Patients can be asymptomatic for many years, or they may develop just chronic stable chest pain. I love that word. Develop chronic stable chest pain. It just means that, they're having angina on an on and off basis that hasn't yet become unstable. How ridiculous is that? But those are words that we tend to use, so we'll keep using them. When the demand for myocardial infarction exceeds the ability of the coronary arteries to supply the heart with the oxygen, that is myocardial ischemia. Let me repeat that. There's a balance. As long as the heart muscle, myocardial, gets oxygen, right, and the coronary arteries are able to supply the heart muscle with oxygen and nutrients, with blood, basically blood, right? Blood has to get to the muscle, right? When that relationship, that ratio changes, let me repeat the words. When the demand for myocardial oxygen exceeds the ability of the coronary artery to supply the heart with oxygen, myocardial ischemia occurs. Infarct happens. Heart attack happens, okay? So just think of angina again as the clinical manifestation of myocardial ischemia, right? And it's caused by either an increased demand for oxygen or a decreased supply of oxygen. Either or, both can lead to that angina. The most common reason for angina really to develop over time is narrowing of one or more of the coronary arteries by atherosclerosis. So really think about this. Coronary artery disease leads because of its atherosclerosis and all that plaque buildup and inflammation and oxidative stress leads to myocardial infarction. So myocardial infarction is probably going to happen after they've been having coronary artery disease, which has happened after they've been having atherosclerosis and plaque buildup, which is happening after they've been pretty much on a lifestyle that is improper dietary stress buildup. And remember, if the most common reason for angina is what? Narrowing of one or more of the coronary arteries because of atherosclerosis, vasoconstriction is playing a major, major role. And if you're living in a society where you have road rage and you're constantly having that catecholamine, that fight or flight stress, so you can go figure. A lot of people are having angina because that narrowing is happening. And if you smoke cigarettes, if you eat high sugars, your blood vessels are going to be full of sugar, your arteries are going to be narrower. So you can see how everything is completely tied into each other. And this atherosclerosis, or this narrowing, right, because of the atherosclerosis, ultimately leads to insufficient blood flow to the heart muscle, right? For ischemia secondary to atherosclerotic plaque to build up, the artery is usually going to be what we call stenosed or blocked, right? 70% or more, or if it's one of the left main coronary arteries, at least 50% or more, then you're talking about a major, major problem. So keep that in mind. Chronic stable angina, I want you to pay attention to these words and understand these really, really careful. The chronic stable angina is referring to chest pain that occurs intermittently, on and off, over a long period of time, with similar pattern of onset, duration, and intensity of symptoms. It often happens because of the physical exertion, stress, or emotional upset or anger, or some type or some other, right? Now, the important thing to keep in mind here, I will repeat it again, is that chronic stable angina generally is provoked by physical exertion, by a stress, or by an emotional upset. Unlike unstable, where you're going to be getting unstable chest pain, unstable angina, when you're just simply sitting down without any stress of any type. That's unstable. If you're sitting down, right, that's why when we ask the patient, when did it happen? When you were having sex, when you were exercising on the treadmill, when you were so on and so forth. You get the point. So asking these questions will determine whether it's stable or unstable. So it's absolutely imperative that we know, right? Again, they'll describe it as squeezing, heavy, tight, suffocation. Dyspnea, fatigue can go, but not always. Chronic angina pain usually won't change with position or breathing and is rarely described as sharp or stabbing. Usually sharp or stabbing is going to be much more of an unstable. So we have to keep that in mind. Again, pain at rest is going to be unusual and is often a symptom of unstable angina. Okay, pain at rest is usually an unstable angina. You need to get that into your mind. Usually we'll do a 12-lead EKG or ECG, I should be saying, which may show the ST segment either depressed or the T wave could be inverted. Potassium could be low or high, depending, which could lead to, well, with the T wave inversion is ischemia. What's really referring to ischemia, but you'll get that in a different class. What we need to understand is chronic stable angina can be controlled on an outpatient basis. We can send them back home. Yes, we can send them on drugs to help them, but we have to have that talk about diet and lifestyle, because chronic stable angina is fully reversible and easily predictable. And the drugs are going to be timed to, provide peak effects during when they exercise throughout the day, right? For example, if it occurs when rising, then the patient can take the drug as soon as they wake up, or wait 30 minutes to 1 hour before they engage in any activity. But ideally, we can prevent that and tell them that they have complete option, complete control in their hands to be able to change things around. This is just showing where a lot of the pains can happen. I'll let you take a look at this on your, and it can radiate and relocate to other areas as well. All right. So silent ischemia is just referring to an ischemia, which is the inability of the blood to feed nutrients and oxygen to a tissue or a muscle. It occurs in the absence of any subjective symptoms. So silent ischemia means it's happening, but you haven't had any. So your doctor told you 3 days ago, oh, you're good to go, and then you have angina or silent ischemia. And we can confirm it with, again, patients usually with diabetes are going to have a tremendous increase, or prevalence, I should be saying, of silent ischemia. And it's most likely due to diabetic neuropathy or nerve that innervate the cardiovascular system. And we can test them with the ECG as well. Here's the types of angina. Again, you need to understand and know what the difference are. Prinzmetal angina is also known as variant angina. We love to give two names to everything. It's relatively rare, occurs at rest, and not with increased physical demand. Usually it's basically some type of a strong contraction or a spasm of the smooth muscle of the coronary artery, which happens because of an increased intracellular calcium. Remember, and that's why we take calcium channel blockers, or we eat, things that we now know are natural calcium channel blockers, like, dark chocolate or magnesium, for example, which we wouldn't be giving in the hospital. Now, magnesium is given on a frequent basis. In fact, if you go into an ECG rhythm, torsades, the best and only solution is for magnesium. When you get that torsades point on, if you see that on that monitor, run in and put your eyeballs on that patient, because they could go downhill and die code blue quickly after a torsades. Now, why I like to emphasize upstream medicine is, for God's sake, why are we not talking to our patients upstream in primary care practice about the need for magnesium, right, and diet and other things before they get into the hospital and have torsades? It's rare, and it occurs at rest is one of the key things that we need to understand. And calcium channel blockers and or nitrates could be used to control the pain. and sometimes and they can be very helpful as well in acute and critical care settings. Absolutely, but so can magnesium. So monitor that magnesium level as well. Another type of angina is microvascular angina. And again, always remember, angina means chest pain. So if you see microvascular angina, it just means chest pain due to microvascular issues, and which occurs in the absence of significant coronary artery disease or spasm, which is more of a Prince metal of a major artery. And in these patients, chest pain is mostly related to MI, right? Myocardial ischemia or infarction, which is associated again to atherosclerosis and ultimately the distal branch of the vessels, which is what we call microvascular. And remember, in diabetes, the damages can be that manifest in metabolic syndrome X patients. They have macro and microvascular damage. Well, same thing tends to happen here. Happens most commonly in postmenopausal women. And it can be prolonged, the angina, the chest pain, could be prolonged or brought on by physical exertion. And this is one of the major differences between this one and the previous one is. So what's the goal for chronic stable angina? Well, we want to try to decrease oxygen demand and increase oxygen supply. So we can give them short-acting nitrates, which is usually the first-line therapy to treat the angina. And basically, we've talked about what the nitrates done. They dilate the peripheral blood vessel, which decreases the systemic vascular resistance, allowing the heart to work less and have to work against less resistance, which decreases the venous blood return to the heart, which is the preload. And really, you want to think that myocardial oxygen demand is going to be decreased because of reduced cardiac workload. So the heart is working less, which leads to hopefully the heart gives the heart time to rest. So if they're taking nitroglycerin at home, for example, they do it, this is key. You must remember this, right? We give it sublingually. We tell them, if there's no release in 5 minutes, call the EMS. If there's some release, if there's some relief, repeat every 5 minutes, no more than 3 times. So you take it, oh, it's relieved a little bit. Take another one, oh, okay, it's going away. You can take up to a third one, always with 5 minutes in between. And if it's relieved, then good. You may not necessarily need to call EMS. But if it's not relieving, call pretty quickly and pretty promptly. And again, some patients who know they're going to be having an activity that will cause angina, going for a run, playing a football game, doing things of this nature, they can take the nitroglycerin prophylactically right before undertaking that activity. And they can take it 5 to 10 minutes before the activity. Just tell the patient to report to the healthcare provider that if there's any changes in the usual typical pattern of pain that they're having, especially if it increases in frequency or they're having nighttime angina, or especially angina at rest. Again, remember, there's some patient education regarding nitroglycerin that we have to tell them. Keep it on them at all time, close to their body, close to where they're at. Store the tablets away from light or heat sources, including body heat. So maybe on the body is not always the best option. Maybe in the car have a bottle, at home have another bottle. If you have 2 stores, put one in the kitchen, one in the bedroom. Protect it, from degradation is ultimately what we're trying to do. So dark area, airtight container, once opened, they start to tend to lose potency. So replace every vial, the little bottle of the nitroglycerin, every 6 months. So keep that in mind as well. Longer acting nitrates are used to reduce the frequency of anginal attacks. For example, and so you want to think about these again in both the previous ones, these short-acting or the long-acting. They're both going to have similar side effects because they're both going to be vasodilating, and the longer-acting nitrates, including again nitroglycerin, tend to if it's given. Remember, there's when you take it initially, you want to consider that there's a frequency of the amount of attack. So if you normally have angina or chest pain once a day, and now you're having it 2 times a day or 3 times a day, you may not be doing any activity, which, you know, in the previous slide we talked about you can consume nitroglycerin before the activity. You can also consume nitroglycerin to reduce the frequency of anginal attacks. And again, remember, all nitrates, the major side effect is what? Headache. You have to know that. Okay, so you have to tell them that an expected, not a contraindicated, it's an expected reaction. We're going to dilate your cerebral blood vessels and overall your peripheral system to help your heart have to work less, to allow your heart to rest. But in the process of that vasodilation, we're going to be giving you a whopping headache. And so they can take Tylenol, you know, just watch out for the liver. Don't take more than 3 grams. Used to be 4 grams a day every 24 hours. Now we're reducing it to about 3 grams because we know that Tylenol is risky for the liver. But over time, headaches may decrease because they build some level of tolerance. What we have to watch out with this medication is orthostatic hypotension, falls. We have to monitor their blood pressure before and after, including their heart rate, right? And so keep that in mind. And you can also give orally something like isosorbide dinitrate, I believe it is, isosortal, or mononitrate, IMDR. That's a common one given as well. Nitropaste usually is going to be 2% nitroglycerin. Topical ointment that we can put by the inch or half an inch, depending on the doctor's order. We put it on the upper body, usually on a flat muscular area, free of hair, free of scars as well, free of open injury as well. Once it's absorbed, it produces anginal prophylaxis, or it prevents chest pain for quite a while, 3 to 6 hours. And especially useful for nighttime or unstable angina. And you should wipe the ointment off to allow for a 10 to 4 hour nitrate-free interval in order to prevent nitrate intolerance. You want to have them on and off, not on a nitrate the whole time, because you don't want them to build that tolerance. All right. We've talked a lot about these in our previous lecture. I'm not going to even go into them here right now. This is another lipid-lowering drug. This is important to know right here. We need to know that when a patient has, or when a patient is suspected to have coronary artery disease, you know, or when a patient has, you know, chronic stable angina, and there is a change in the anginal pattern, more frequency, then so you have a patient who's in the hospital, and we know they're there for chest pain. But if they start having significant, much more chest pain, and they're complaining about it, doctors need to be notified, and there'll be a series of things that we're going to start to be taking with them, including usually a 12-lead ECG, which they'll do to build a baseline when they first come in the hospital, and we can always compare it to that. If they get to your floor, they don't have one, it's probably not a bad idea, especially if they're here for angina, to see if you can get one. A lot of them may be going to an exercise stress test with or without the echocardiography or nuclear imaging, but that may be ordered. Patients who may have limitations in walking won't get the physical stress test or the bike or the run and all that. They'll get something like adenosine, which is a pharmacological stress test that stresses the heart, to try to then measure and see if there's any coronary artery blockage. And I won't go into the electron beam at this point. Just know that these are some of the most, in laboratory studies, you already know. The key one is which one? Can anybody think about it? You should already know it off the head. Mostly troponin as well. Troponin is going to be the one that we're going to want to do. You could do lipid profile. You could do C-reactive protein is another thing that we've added onto it. You may be doing homocysteine. So if you have a patient that's there for CAD or any heart-related problem, and you see that they have had labs, start paying attention, look closer for CRP or HS-CRP and homocysteine, as well as that troponin, or the BRP for CHF or chronic heart failure over time. So for Other interventions, patients that have over time increasing angina, they may end up having a cardiac catheterization. Another word, you'll hear coronary angiography, and we do that coronary angiography by putting a catheter in through either the femoral groin up to where that artery is, or we can put it through the radial. Some hospitals, it depends on the surgeon and what their proficiency level is. Some surgeons will go through the radial. I love patients who are coming back with the radial. They have this radial little band on that you can inflate with air, and then you just deflate. Let's say it has 10 cc's or mLs of air, and then you just deflate 2 cc's. Every hospital will have its policy, but basically you want to reduce the pressure over time. If you start to see that it bleeds, you puff it back up to the last 2. So on and so forth. And if they come back and they had a cardiac catheterization through the groin, then you need to monitor for bleeding. Now remember, you want to palpate both sides of the groin, not only the one that they went in through, because you want to look you want to use anatomical sites to see if there really is bleeding. Now, it sounds horrible when you say that. I prefer patients who come back and when you look at the wound, it's bleeding everywhere. I prefer that because you can see that it's bleeding and that it requires us to put manual pressure on it for a significant length of time to control the bleed. The tricky ones that are trickier are the ones that have bleed within and underneath that groin area, so that when you put your hand down on that groin area, you really want to feel every 15 minutes, go back and feel both sides, both femoral sides, and you'll start to feel a little bit of like a little pebble, like a pea. And then the next time you grow, it's more like a nut. And then the next time you grow, so you automatically can start to detect and know that there is bleeding happening underneath, and we need to put some pressure on that right above where the bleed is probably happening. And remember, we use this cardiac catheterization for revascularization as well. With the PCI, you really need to know this name, right? Percutaneous coronary intervention. That's when, so the cardiac catheterization, when we go in through the groin or the radius, and we go to the heart, we're using it as a diagnostic tool to look and visualize to see if there's blockages. If there is, and it's significantly large, 70% or above, depending on, or 50% if it's on one of the major ones, the doctor may deploy. So that catheter that we put in has at the tip the option to deploy a stent, and so they can leave the stent in place, and basically that's what we call coronary revascularization. Revascularization basically means we're going to put the stent in, open it up, and let that blood get through to the other part of the heart that was slowly dying because blood wasn't getting there, nutrient and oxygen wasn't getting there. So we want to really reperfuse and revasculate that area as soon as possible. And during a PCI, remember the catheter will be deflated, the balloon tip will be deflated, will go through to the coronary artery. It's positioned right where the blockage and inflated area, right at that area. And then this compresses the plaque against the artery wall, resulting in vessel dilation and a larger vessel diameter. Which, then with this procedure is what we call a balloon angioplasty. If they're using a balloon, that's what you'll read on the doctor's surgical note, procedure note, balloon angioplasty. And then intracoronary stents are usually placed along with that balloon angioplasty. They'll puff it up and deploy the stent. This is just showing you what they're trying to do. Now remember, if we know that tobacco, for example, or high sugars, adipose tissue, that fat that leads to the buildup of the plaque. So if we know that sugars and tobacco, two things, sugars and tobacco, right, are leading to this buildup to nicotine because of its vasoconstrictive, they're having to go to the hospital paying tremendous sums of money, insurance, through the insurance and all of that, to get a stent placed for something that could have been prevented by tobacco and sugar elimination. And so if a patient is in your floor and they had a stent or they're going to get a stent, please make sure that we have this talk with them. And now, one thing that's really important with this is notice that it's a mesh, and these meshes put patients more at risk for platelet aggregation because of that stent. So a lot of patients, when they're during the PCI, they're going to get some form of heparin to inhibit that platelet aggregation, so they'll thin the blood a little bit. And a lot of patients will end up having to be on some form of a antiplatelet drug, whether it's aspirin or Plavix, indefinitely. 12 months, maybe more, maybe for life, because we want to keep that blood a little bit on the smoother side, because having this stent in place is going to put them now at more risk for that buildup. And there's basically two types of stents, a metal one and a drug-eluting stent that already has some type of a drug in it to reduce the risk of overgrowth of that intimal lining and all of that buildup that we already know leads to coronary artery disease and so on and so forth. Now, the most serious complications from stent placement and abrupt closure of coronary artery dissection and vascular injury at the artery access site, whether it's femoral or radial, and I just talked a little bit about that. And it can cause a whole bunch. They could have an acute MI, stent embolization, coronary spasm, dye allergy, renal compromise. They could bleed. Bleeding is a big problem. And again, if they're bleeding outward, I love it. I see it. I put manual pressure. We control it 10 times out of 10 times. I've never lost a patient due to bleeding from one of their femoral or radial sites. But what you have to monitor are those that have internal bleeds, because if it goes into the retroperitoneal area, they're at high risk. And again, the possibility of dysrhythmias during or after the procedure are always present there as well. There are alternative therapies for patients. I'm not going to go into any of these right now. I won't expect you to know any of these. This is just an image that shows, the A image shows an occluded artery, and the B is the same artery after the PCI, after that revascularization, coronary revascularization in the stent. So you can see on the left side, where they go in with that catheter, they throw that dye in there, and it shows that this you will see in an active form. You'll see the body, you'll see the movement of the vessel. So it's kind of like watching with the camera. And you see that really thin line right there. That just means that blood is not getting to the other side. So perfusion is not happening, ischemia is happening, and all of this could have been prevented with lifestyle, upstream, de-stressing, so on and so forth, as you well know already by now. But when they're having an acute coronary syndrome and they're in the hospital, we get that stent in there and look what happens. Boom, it fattens up and right there and then. The problem is patients are going to come back and they're going to get a second and a third. I've known patients who've told me they've had up to like 5, 6, 7 stents. I think one of our students, not from your group, previous group, father had up to 11 stents. And the student, I asked the student, did anybody ever talk to the father? No, nobody even mentioned that diet played a major role. So again, coronary artery disease, acute coronary syndrome is basically when you have ischemia that's happened and developing over a long period of time that is not immediately reversible, right? Not immediately reversible. If somebody comes in, they have stable angina, you tell them, hey, take nitroglycerin, everything goes okay. We did that cardiac catheterization, but they didn't have any obstruction. We didn't have to deploy a stent. We can send them home, right? That's not necessarily an acute coronary syndrome. Acute coronary syndrome is really when patients first present with chest pain and they have on that 12-lead ECG that we tell you we do, ST elevations, ST segment MI or a non-ST MI can still be an acute coronary syndrome. It's really difficult to distinguish between an unstable angina and a non-STEMI. Until when? So how do we know that it's a non-STEMI, right? Non-STEMI means non-ST elevation MI, STEMI, non-STEMI. Non-STEMI is still an acute coronary syndrome, but of the two that are unstable and non, how do we know? Well, we know until the serum, the blood cardiac biomarkers are measured. And again, on the cellular level, when the heart muscle becomes hypoxic, meaning not enough blood getting to that area, within the first 10 seconds of a total coronary occlusion, right? So the heart cells are going to be deprived of oxygen and glucose, which are needed for the aerobic metabolism and contractility, all of that. And then what happens is anaerobic metabolism kicks in, and that begins with, that's what the lactic acid accumulates, so on and so forth. So in ischemic conditions, heart cells are really viable for about 20 minutes. So time is of essence. Irreversible heart damage is going to start after 20 minutes if there is no collateral circulation. So if they haven't built up that collateral circulation we talked about earlier, they're in big trouble. So you can see that coronary artery disease is just a big umbrella term that we use. But when we talk about acute coronary syndrome, that's most of the patients you're going to start seeing show up in the hospital. So acute coronary syndrome, again, it's no different in terms of its etiology and its pathophysiology. It's caused by, the decline of what once was a stable atherosclerotic plaque, and, the previous plaque, stable plaque, for example, ruptures, and it releases that substance into the vessel. And this is going to stimulate more platelet aggregation and a thrombus formation. And it's a catch-22, right? The area may be partially occluded by a thrombus, and that may lead to an unstable angina or a non-STEMI, or it could be totally occluded by a thrombus. And if it's totally occluded, you're probably going to get more of a STEMI than a non-STEMI or an unstable angina. Now, what causes a coronary plaque to suddenly become unstable, it's not understood yet that well by science, but we know what leads to the plaque buildup, and that's lifestyle. That much we know. And systemic inflammation, which we've talked about before, is known to play a major role. And again, patients that have a suspected ACS, acute coronary syndrome, require immediate hospitalization. And that can be an unstable angina. Usually stable angina will be sending them back home. And hopefully people are talking to them about diet and lifestyle. Clinical manifestations of unstable angina, again, is chest pain that is new in onset. It occurs at rest, or occurs with increasing frequency, right? So they may not have it at rest, but if it's happening with more frequency, still is unstable. I hope that point is clear at this point. If duration increases or with less effort than the patient's chronic stable angina pattern. So if earlier it took them to walk from downstairs up the stairs to the bedroom, and they would get angina up there, then they would take that nitroglycerin, and now they can't even make it to the steps. That is a change in the pattern. So prompt treatment is going to be needed when suspected in patients that are having this unstable angina. And the patient with previous diagnosis of chronic stable angina will now need to be labeled as a pattern of angina that is becoming unstable, or putting them at risk for acute coronary syndrome. And unlike chronic stable angina, unstable angina is really unpredictable, and we need to treat pretty immediately. So that's something to always keep in mind. But again, this has been happening for a long time, and so patients get this fear factor put into them with reason, because they're having unstable angina. But we need to tell them that, okay, you're in the hospital, we'll get that stent in, we'll do what we need to do, but when you get out of here, if you want to make sure that you don't have to come back for stent number 2, 3, 4, up to 11 or more, yes, now you need immediate treatment, but there's a lot of things that you could be doing before even CAD is diagnosed. So myocardial can infarction, MI, myocardial infarction, that's the official definition of heart attack is myocardial infarction. Don't confuse myocardial ischemia, which is the beginnings of that lead to the infarction, but MI, myocardial infarction, is a heart attack. Occurs basically because of an abrupt stoppage of blood flow through a coronary artery, because of that thrombus or that platelet aggregation. And this is going to cause an irreversible myocardial cell death. We call that necrosis of the tissue. Remember, time is of essence. So most MIs occur, in the setting of pre-existing coronary artery disease. And again, necrosis, all of that end up leading to all these complications. A STEMI can be caused by occlusive thrombus, we know it's a STEMI because of the ECG. And with STEMIs, in the emergency situation, in order to limit the infarct size, that artery is going to have to be opened within 90 minutes. You need to know this. within 90 minutes. If there's a STEMI, what are we going to prepare the patient for? We're going to prepare them for PCI. We're going to prepare them for, well, we're going to prepare them from two things, either PCI or some type of a fibrinolytic therapy, like a thrombolytic, right, to break that up. PCI is going to be the preferred treatment if a hospital is capable, so it has to be a heart center, a stroke center in some cases, but mostly, and then the non-STEMI can be caused by a non-occlusive. Again, it's not fully occlusive, won't cause that ST elevation, that STEMI. Patients may or may not have that STT wave change, but non-STEMIs will not go through the cardiac catheterization emergently, but usually undergo, they'll be admitted to the hospital, and within, a day, 2-3 days, up to 72 hours, as long as there's no contraindication, they may go through a PCI at that point. But the thrombolytic therapy is not indicated for non-STEMI patients usually. Now, a non-STEMI patient, while they're your patient, could go into STEMI, which is why we have them on a cardiac monitor, because once they go into STEMI, we do need to do a PCI or a thrombolytic to break it up. Now, with either of the two, non-STEMI or STEMI, the ECG could show, worsening of the myocardial contractility. That's hypokinesis, or akinesis. Absolutely no myocardial contractility. That if they do that, if the doc reads this and it shows that there's akinesis or hypokinesis, that means that the necrotic area is going to be pretty bigger, and that's going to be shown or demonstrated by the left ventricular dysfunction, which depends on the area of the heart involved and the size of the infarction, but you'll get more of that in third and fourth semester. This is just showing, the process of acute MI over time, and where the blockage is happening. If ischemia persists, it takes about 4 to 6 hours for the entire thickness of the heart muscle to become necrosed. So within 4 to 6 hours, that tissue could become dead. And if the thrombus is not completely blocking the artery, the time could be as long as up to 12 hours. But if it's a full blockage, 99%, 100%, pretty much 4 to 6 hours, and then it's dead. And here is just the left ventricle where that arrow is. That's demonstrated by the necrotic area. See that white tissue? Note the scarring, right? That's what this is indicating here. Pain is important, right? Severe chest pain not relieved by rest, position change, or nitrite administration, or those are clinical manifestations of acute coronary syndrome, myocardial infarction. This people right here, this is a heart attack. Radiates the neck, low jaw, substernal. In women, it may be atypical, right? And in the elderly, and in a lot of the patients that have diabetic neuropathies, and they're on, some diabetic medication, they may not have that sensation of pain, so they're even more at risk for having the problems that they have. Again, with acute coronary syndrome, myocardial infarction, can't tell you, at this point you're already in the hospital, so you're already going to be stressed, and so we need to talk to the patients again about what they can be doing upstream, because once they're in the hospital, they're already releasing a lot of catecholamines. Like which ones? Can you remember? Norepinephrine, epinephrine, right? That are normally found in a lot of these cells. And this is going to release glycogen, diaphoresis, increase heart rate, blood pressure, vasoconstriction. It's going to vasoconstrict the peripheral vessels. And the patient could start looking ashy, clammy, cold, cool to touch. So if your patient is good, he's there for non-STEMI, and you walk in and you have a patient that is now ash colored, clammy, sweating, cold to touch, what do we need to be thinking? People, the sympathetic nervous system is kicking in, and this patient is struggling. Their heart is struggling. That acute coronary syndrome, they're having a myocardial infarction right in front of you. So we need to make sure we notify the doctor and do the right things that we need to do as we go through. So remember, in response to this, that release of catecholamines, BP, heart rate also are going to increase initially. So don't get confused. Initially, they're going to increase. Ultimately, the blood pressure is later going to drop. Why? Because of a decreased cardiac output. If it's severe enough, it may even result in decreased renal perfusion and decreased urinary output. So if you're not monitoring urinary output in your patient, that is in the hospital for a heart attack, shame on you. Monitor that urinary output, because if it starts to decrease, it means that. But generally speaking, you'll start to see the blood pressure decrease before that. Now, again, crackles can be present and could persist for hours or days. The crackles can be a manifestation of left ventricular dysfunction. We also use JVD, or jugular venous distension, hepatic engorgement, hepatomegaly, large liver, peripheral edema, which is also the hepatomegaly and splenomegaly are mostly of the right ventricular dysfunction. And again, what do? We examine the patient to see what their heart sounds are. If they have lub-dub, that's S1, S2, good. But if they have lub-dub-dub or lub-dub-dub, lub-dub-dub, S3 or an S4, an extra sound, we don't like that. If they have some type of murmur, we need to be aware of that. Is it new? Do they know if they have a murmur? Is it history? Because a lot of this could indicate some type of a septal problem or ventricle. Basically, their muscle could be having, or their valve could be having a problem. So a lot of things could be going on. So we need to do our focused assessment on the heart and listen to the all patients take meds, apical, right, on the right side of the heart to listen to the apex of the heart. You don't listen to the apex on the left side of the chest. You listen to the apex of the heart on the right side of it. That's why we call it the apical heart rate. Anyways, other clinical manifestations because of that reflex stimulation. Vomiting could be caused by the severe pain, or they could also use vasovagal reflex could be initiated because of the infarcted heart muscle. The temperature could increase to 100, 101, something like that within the first day or two, 24 to 48 hours, and it can last for up to 4 days or so. This increase in temperature is usually, again, due to systemic inflammatory response caused by the death of the heart cells. Okay, healing process. So within 24 hours, we're going to hopefully get that leukocytes. This is really going down to that molecular level. I'm not going to expect you to know any of these things right here, right now. Let's go to the next. At day 10 or 14 after the MI, the new scar tissue is probably going to be weak. The heart muscle is going to still be vulnerable, but they're going to be healing at this point. Let me go back actually to that last slide. Yeah, no. So we already know about the troponins. Let's go by 6 weeks. We're going to have the MI scar tissue is going to be replaced by necrotic tissue. The area will be said to have completely healed, but it's going to be less compliant. Once necrotic, it doesn't go back. Once dead, it's dead, right? This is where an ACE inhibitor could play a role with ventricular modeling, because the normal heart muscle, myocardium, is going to enlarge, hypertrophy, and dilate, and in the attempt to compensate for that infarcted muscle, and it could lead chronically to heart failure. But remember, especially in the people who have atherosclerosis or other already CAD, coronary artery problems, ACE inhibitors can be given to limit that ventricular remodeling as well. Dysrhythmias, you're going to get this in a whole class. I'm not going to go over that. We got a lot of slides to still go through. So the JVD is most present with right-sided heart failure, restless agitation, mild dyspnea, with left-sided heart failure. This is important to know. Lower extremity edema could happen with both, but remember, right backs up to the body, so right is going to back up to the lower extremities, the liver, and to the spleen, so those enlarge, so the legs. But heart failure in general, congestive heart failure especially, lower extremity is a hallmark sign and symptom, so it's hard to differentiate left or right between those two. I'm not going to talk about cardiogenic shock here, other than basically it occurs when oxygen and nutrients aren't getting to the tissue, and left ventricular failure is severe, and so on and so forth, leading to ventricular infarction, and leading to the whole need for rapid treatment of that STEMI with a PCI or a thrombolytic therapy. And we do need to, with the MI, cardiogenic shock really is, we need to treat really quick, and the goal is really to maximize oxygen delivery, reduce oxygen demand, as we've talked about, and prevent complications like what? Like, again, that kidney, perfusion to the kidney, or acute kidney injury, which would be a pre-renal injury. The heart had a problem, now the kidney has a problem. It's not an intrarenal, it's not a post-renal, it would be pre-renal, which you'll get as well in a later class. Complications, let me see if I expect you to know anything about this right now. Um, no, let's see. No. All right, let's go to the next. Ventricular septor. Usually with ventricular septor walls, a new or loud systolic murmur that is in the hospital for an MI, think about it could be a sign for ventricular septal rupture. We need to really pay attention to murmurs, new loud murmurs, and the patient must receive really emergency repair surgically or percutaneously if possible, because otherwise the patient could die. So that's important on this slide to know. Acute pericarditis, again, pericarditis is an inflammation of the visceral or of the pericardium, pericarditis, right? But it could be the parietal or the visceral part of the pericardium, and it could happen 2 to 3 days after. This is a big thing to know. All MI patients, 2 to 3 days after having an MI, are at risk for having pericarditis. Again, all MI patients who's had a heart attack 2 to 3 days later could be having pericarditis. And it's going to be manifested how? By severe chest pain that could happen. These are patients that already had a PCI, already had a stent, and now they're going, severe chest pain with inspiration. You ask if they cough or breathe in or movement of the upper body, or if you ask them to sit forward and it's relieved. Again, pay attention to all of those things. If they're having severe chest pain with breathing in or cough or movement of the upper body, and you say, here, sit forward, see if it helps you, and if it relieves that pain, we know there's pericarditis is a high problem for this patient. And so, we need to assess them for that typical friction rub over the pericardium. And so you want to use the diaphragm of the stethoscope over the mid to lower sternal border and listen for friction. It could be